Thank you, Dr. Olson. Great finish to this talk. So if I can ask the panelists to join me up here, and we'll begin our question and discussion portion. If you could go to the microphones, and just a reminder, if you could identify your name and your group that you represent as we begin our questions. Maybe we'll begin over here.
Hi, thanks. David Grimm. I'm a reporter at Science. I guess this question could have been asked at any panel during the conference, but since there was some discussion of cats at this panel, I thought I would ask it. As Dr. Olson mentioned, there's more cats in U.S. homes than dogs, although a larger percentage of homes have dogs. As many owners consider their cats members of the family as dogs. We've lived with cats for thousands of years as dogs. And as was brought up yesterday, a lot of the environmental insults we talk about with dogs being exposed to the same environment that we're exposed to, obviously we see with cats as well. They live in our homes, they eat our food, they're exposed to a lot of the same toxins and things that we are. So I'm just sort of curious why there hasn't been more discussion of cats and cat clinical trials. Is it just because cats are harder to work with, as any cat owner knows? Is it that we just don't have as much data on cats, and so it's harder to conduct these studies? And this is just for all of you. I mean, I was just wondering if you could comment a little bit about why we're not seeing more of a discussion of clinical trials with America's other favorite companion animal, cats. So,
Raji or David?
Yeah, I think you kind of hit the nail on the head as far as we have less baseline information in some aspects. Some of the things that were talked about over the last couple of days, body size, but also cats, many of us think are not from this world. They were dropped here by aliens. And when you look at some of the metabolic factors associated with cats, the way they metabolize some of the drugs that we deal with that we just can't give cats, that both our dog population and our human population can take without incident, has either rightly or a poor perception of the fact that maybe they're not a good model. And I certainly bring that up all the time, that they are orphaned, and we really need to do a better job of inclusion as far as for clinical trials, at least from the standpoint of animal health.
Yeah, cats are included in all of the discussions. It's just what's the right sort of opportunity. Cats, for instance, can develop an extremely aggressive form of breast cancer. It can be double or triple negative if you compare it to breast cancer in women. It's a challenging population from a number of standpoints. The cat has a different metabolic system in terms of certain drugs that they have the incapacity to be able to metabolize well, and can have different types of toxic syndromes. And it's true that cat owners in general do not seek as much veterinary care as dog owners. So we know that we can make a real strong impact in certain areas, and we do that. In fact, I think outside of cancer, there's more opportunity for the utilization of clinical trials in cats. Chronic renal disease is a huge issue for cats, and that's a source of a number of clinical trials. And other types of infectious disease studies, this concept of comparative medicine or one medicine, I think I think the cats are represented more in that context.
Rod, just a follow-up. AVMA is very interested in getting more cats to private practices with cat-friendly practices, and there is a national movement that's supported by the AVMA to do that. The AVMA also is interested in clinical trial registry, and there is a proposal that has been put forth to the board at the AVMA on clinical trial registry, and it's very important for that organization to get involved deeply in this discussion as well. Let's go over here. Dr. Locke, can you introduce
Thank you. I'm Paul Locke from Johns Hopkins Bloomberg School of Public Health. That was a great panel. Thank you, panelists, very much. And I wanted to ask a question that I think the last speaker, Dr. Olson, may have brought up. And if I get this wrong, it's my mistake. And if I get it right, I need to give you credit for this. But I wanted to ask all the panelists, especially those who reported on the workshop, the ethics workshop, about this issue of IACUCs and IRBs. Those are quite different in the questions they ask and the focus. So the first question I have is, should we have an IRB-like approach or an IRB for clinical trials involving animals? The second question I wanted to, well, maybe I'll just leave it with one question. There's a lot of people here, so perhaps I'll just stop there.
Thank you.
Yes, thanks for the question. I think in many ways, these clinical review boards that are now in place to assist as an advisory committee to the IACUC are capable of serving as essentially an IRB. They can also be asked to have other duties if that's part of the mandate and part of the resources that are adequate. They often get asked to review consent forms. They'll often be asked to do potentially some of these post-approval monitoring concepts and things like that. So I think the idea of an IRB-like concept is important, but at the end of the day, animal research is still governed by the government in terms of IACUC approval.
Just to follow up on that, when I did some consulting work for American Humane Association, which has, since it was established in 1877, has both an animal protection division and a child division. And when we would do surveys that involved both of those constituents, we had both IACUC and IRB approval.
Very good. Over here.
Kurt Weingand, Midwestern University. If I can just follow, part of my question was exactly that, and I just wanted to echo the question that you asked, Patty, why don't we have a veterinary IRB? We came pretty close in the last year. The AVMA Council on Research, Dr. Harry Dickerson at the University of Georgia had led an effort to put forth a recommendation for development of a veterinary-specific IRB. And oftentimes, like Congress, when a bill goes in, what comes out at the end is approved. This is not the same thing. And so it was a very distinct recommendation, but it came back similar to the recommendation that Rod, you shared in the ILAR publication, with where we are with now a clinical research committee being an interface to the IACUC. But I really think in the long term, it would be really great to align the same process that is used in human clinical trials as is used in veterinary clinical trials. There is a different question that's being asked. It's for human trials, it's about the protection of the safety and the privacy and the rights of that person. That's the same thing we should be looking at in protecting vulnerable patients, and that's who pets are, as you have pointed out, Patty. Just an aside. My question was this issue of the placebo, and I didn't catch the reference that you said, Patty, about somebody saying not to use placebo, although I know that some of the approvals that have gone through the Center of Veterinary Medicine for animal cancer patients have had large placebo groups in it. So what is the panel's recommendation going forward?
Yeah, I think, the term placebo, there's a couple of issues involved. One, the Center for Veterinary Medicine, if there's not an approved drug for that particular species, they usually require a placebo. However, thinking of it in the way that we've adopted the protocols over the last few years is that placebo really means best supportive care, or should mean best supportive care. And we have a population that often does not want to go ahead with quote-unquote standard of care, but wants to alleviate pain, alleviate gastrointestinal signs, essentially a hospice type of environment. So when we set up trials that are randomized or required to randomize into a placebo effect, there's certain safeguards that we can put in. One is to ensure that best supportive care is really the control group rather than quote-unquote placebo. Second is to have a very early tripwire and an approved tripwire, as far as if you are having a placebo group, that if there's progression of disease that's caught early and they're transferred out of trial either to best supportive care continuation and euthanasia when considered appropriate, or crossover into a treatment group. Other things that can be considered, and these are all things that we've discussed over the last few years, is unequal randomization. If we know a lot more about the natural history of the particular disease, then that can be randomized into a smaller placebo group if we know the natural history. In veterinary oncology, certainly, we know much less about the natural history of many of our tumors. So in many cases, we learn a tremendous amount about whether a particular disease needs to be treated aggressively up front or not, based on those best supportive care groups. And so that's valuable information that we can transfer back into our clinics and increase the quality of life of our patients as well. So there's certain things that we can do at this point. We always try and either eliminate or decrease the placebo control group or the best supportive care group until we know a little bit more about the natural history, or until we get access to drugs that we know work, that have a higher likelihood of having efficacy, which we can put in the control group. Having randomization to standard of care plus the new investigational agent or standard of care. Those are the types of issues that we're dealing with right now, but those are really important questions.
But we need a microphone, so if yeah.
I also just wanted to add to that from a clinical trial perspective, that it's well known that we really don't try and look at efficacy against placebo anymore in humans either. So it's always against a competitor drug or the standard of care of that time, because looking against placebo is usually not demonstrative statistically of an effect, and that's also why the PD marker is so important. So I don't even think that would be an expectation if you were partnering with pharma, that they would expect you to have a placebo group if there was care that could be given.
Yeah, if you could, just a reminder, everybody, if you could identify yourself and who you represent.
Tanya Zapka from Genentech. Sorry.
Thank you. Jeff, I think you were next.
Okay, Dr. Jeff Trent, I'm at TGen. Just a comment and then a question. I was in the overflow room raising my hand, Patty, when you asked. I think it is reasonable to point out that PetSmart provided a framework for us using social media to be able to send emails out. They groom 80,000 dogs a week. We asked them whether they'd send out emails to those that had a particular haircut that they gave to a dog of a particular breed that we were interested in, not to get disease information, but to be able to contact them for a swab to look for just healthy dogs for controls. And they sent out 141,000 emails. There were only a handful that came back, because these are the cards you use to get your discount. And so and it was a remarkable response that allowed us to get hundreds of samples in an extraordinarily short period of time. So I think working with those have great value. So that's just the comment in regards to that. The other, though, is in regards to the standard of care component. You heard yesterday from the AstraZeneca representative, and I know in our own phase 1 program at TGen under Dr. Von Hoff, almost 80% of phase 1 clinical trials in humans now have a response. We no longer really look at phase 1 trials as simply dose finding in the human. On the other side of the coin, with the veterinary physicians that we've been working with on our clinical trials, all of them believe that we should have standard of care first and then follow with phase 1. So I do believe that is a component and I'm just trying to understand whether, I think I was surprised as a non-veterinarian that we would not be willing to move in advance, because we're always asked by our human patients, do I have to get standard of care? We're always asked that before receiving something. And I realize it's sort of controversial, but the thoughts maybe from you on where phase 1 trials come into this, and again, with the recognition that all the vets we've worked with have said we need to mandate that going forward.
I'll just have one comment on that's often the case when I present, especially with some of the diseases that we need the most help with, some of the cancers. And I gave the example of hemangiosarcoma. When I explain what standard of care is to my clients and what the outcomes associated with standard of care, they go, isn't there anything else we can try? And I mean, that becomes really obvious with some of the devastating diseases that we deal with. And so in situations like that, I tell them and I try to thoroughly explain what standard of care is and what the outcomes are, and that we are looking at novel agents. And as was said today and yesterday, the expectations for efficacy in phase 1 trials are much higher than they used to be. And you have something to add?
I think it's great that phase 1, phase 2 trials are blending and that there's a higher recognition of the need for these types of studies that will reduce patient populations at risk of either too low a dose or too high a dose. But I think not so much that, whether we should do it or not, but how do we build the communication skills to be able to talk about the concept of the trial regardless of placebo, naive patients versus refractory patients or standard of care. I think that's really the point where there's a teaching moment to get some help, understand what sort of information does the owner, pet, parent need to know. How do we be as forthcoming as we can with the situation that we deal with, and feeling strong in our confidence that we've created a really excellent consenting process.
We're back over here.
Hi, I'm Lily Duda, University of Pennsylvania. I just have a comment about the placebo, whether you call it placebo or no treatment or best standard of care, is something to keep in mind is that pet owners always have the option of doing quote unquote no treatment. And it's actually quite common, particularly in oncology, even if there are good treatment options that work well, that we think are pretty well tolerated, an owner always has that option and often will choose that option for a variety of reasons. So I think that, I certainly, if you're going to call it best standard of care, even if it is a placebo, or even if it is no treatment, I think that ethically that is acceptable, should be acceptable compared to a human clinical trial. It's often that when owners will hear all the options and then they'll say, well, what happens if I do nothing? I'll always correct them and say, well, you're never doing nothing. You're doing supportive care. It might not be disease-directed treatment. So maybe that's what a placebo should be called, is no disease-directed treatment. You're still doing something. And I think that is an important distinction, which is one of the reasons I think the canine companion animal model is such a good one. And then just one more comment, if I could. In terms of all the questions about whether or not there should be a veterinary IRB rather than just the IACOC for clinical trials, I think that a lot of institutions that are doing the protocol reviews really are doing a de facto IRB, so it may not be mandated per se, but I think a lot of the places that are doing a good job are using the IRB model, because why reinvent the wheel, right? Somebody's already worked out all those questions about can somebody really give true informed consent or whatnot. So I think a lot of people are already doing it very well, and you should look to those places that are doing it well rather than trying to reinvent it or having it mandated from outside.
Thank you. Good comments. As far as being, and I was in practice for several years as well, and totally understand owners who sometimes elect no treatment. But as was also stated yesterday and today, a lot of times that's also based on the economics. And so we have to be careful, again, how we incentivize and really considering that owner and its pet. We do have third-party insurance now for pets, but it's less than 5%. And I just read, I think it was in Veterinary Practice News, for the first time that industry went over $1 billion. So not huge, but growing. Unlike Sweden, where 80% of the dogs in Sweden have health insurance. And so they're very aggressively looking at their database and have another way to look at the health of animals as they enter into the whole family health situation. But good comments.
Thank you. Over here.
Daniel Promislo, University of Washington. Expanding on this issue of experimental design and placebo-controlled, I wonder if you could talk a little bit about the importance from a scientific design perspective of running these trials double-blind with the particular challenges of this setting.
Yeah, we certainly try and do double-blind, and some would consider triple-blind, but we don't have to blind the dogs as far as which treatment group they're going in, or the cats. And we do to the best of our abilities when it's necessary. We've even gone to extremes of where one treatment group is getting an injectable and one is getting an oral, is that putting in a catheter and giving a saline and having placebo pills or non-treatment pills. So we try and do that to the best of our abilities. If we can get around that by using as objective measures as we can, PK/PD measures, true response measures that are based on clinical measures, criteria that remove as much of the subjective as possible as well.
Thank you. Over here.
Yes. My name is Amy Cable, and my background is I have a PhD in education. And the reason that I'm here for the conference is because my dog, Hank, was diagnosed with a soft tissue sarcoma in February of 2013. And since then, I've got like a new passion in life to try to help animals with cancer. So my question is, what can I do as a pet parent to help raise awareness, money, to try to help make a difference?
Thank you, Amy. That's such a wonderful comment. And so I think you'll have such a great appreciation after this that there are so many opportunities that we don't know where to start. But we would welcome your background in education in terms of helping us build a communication plan to reach other individuals such as yourself and the community as well to raise awareness, improve the networking capabilities, promote the opportunities that exist that we can sort of integrate better the process of innovation between animal health and human health. So I think we'd be happy to have further conversations with you about what an educational plan might look like.
Along that same line, scientists are notoriously horrible, and I can say that as one, for communicating science. Great in doing science, but communicating it to the public, Amy, we're not so good. And I can give you an example. When I was at Morris Animal Foundation, with the final report, we always ask for a lay paragraph. Tell us in lay terms what you did. They couldn't do it. I mean, I remember calling a colleague of mine who I absolutely adore, who's done fabulous equine research, and saying, polymorphism is not a common household term. He said, really? So yeah, we definitely need your help, because science to stories and communicating to the public is hugely important.
Over here, back over here.
Hi, Nick Dervasis from Virginia Tech. Kind of, that was a great segue, touching. How do you obtain an informed consent, not from people that speak a different language, but in people that belong potentially to a lower socioeconomic status? How do you, what we struggle as a new service at Virginia Tech is we have a number of clients that I bet they don't understand the statistics and the risks, and their primary advocate, the general practitioner, pushes them into the trial, and we're pushing them back, saying, you don't understand, maybe that's not good for you. So how do you really try it? I would like the panel's opinion.
There's some tremendous tools that are available now for consenting in people that have different languages or different socioeconomic issues related to videos, teaching types of interactive apps, all kinds of really innovative things that we have yet to even think about, doing a lot of the education in a way that's relevant. And I think the same situation exists in human patient populations that are in trials. So I'm sure that many of those solutions have already been developed, but for the time being, it's going to require some really interesting development of other types of teaching opportunities. And I understand what you're saying.
One of the things that is occurring at the accreditation level is multicultural competencies. And I think as we begin to teach our veterinary students that, it'll help a lot also in, as it filters down through the practice. Over here, Doug.
Doug Tham from CSU. I wanted to ask actually everybody up there, but also the clinical research colleagues in the audience. David brought up the really good point that to some degree we're able to streamline the phase 1 process through our interpretation of normal dog tolerability and safety data. But as sort of early phase investigators, should we consider that need to have, or should we consider that nice to have information? Should we ethically move into client-owned pets with no normal canine safety data? Thoughts?
Yeah, that's a really good question, and one that, because of the regulatory process, both on the human side and the veterinary side, there needs to be some normal species work, at least in a couple of species. And so it's often removed from us in the fact that if a drug is brought to us by pharma to investigate, there's already normal dog data in there. And so that's very helpful to us. But from a standpoint where there isn't, right now, many of the IACUCs and the IRBs do require some degree of normal dog work. It could be as little as a cohort of 3. And so some of the time our hands are tied, and we're in a process right now of educating both, and it's kind of a cross-education with our IACUCs and our IRBs, and also with the Center for Veterinary Medicine at the FDA, to point out that they never have normal human data before they move into patient data, and that we really should be moving towards that. We can use the same safeguards. We're not reinventing the wheel here. And I personally believe that if we don't have normal animal data, that with the appropriate study designs, we can go into disease-bearing patients right away.
Over here, Doctor.
And so I'll pick up on Doug's question, and David, I fully agree. I think there are, but more broadly, to just come back to a comment that Patty made. And so I think in every decision-making process that we have with clients, we have the same discussion, whether the discussion is about a conventional therapy approach or a clinical trial. And from my perspective, that's discussing with the client what their goals are, what their acceptance of risks are, and what their view on costs are. And so that same discussion happens irrespective of whether it's a clinical trial or a conventional therapy. And so it's my opinion that our job as clinicians is to give people the information so that they can make a decision. And so that information is the same if it's a conventional therapy or a clinical trial. And then if we do our job, then they can decide for their family if a clinical trial before conventional therapy is in their best interest, or they can decide if the ineffective conventional therapy is in their best interest.
Yeah, and I think that's the issue. Can we communicate it clearly, consistently? How do we assess that they understood what we said? How do they understand what the short-term and long-term effects are? We heard yesterday about 40-year-old people that are now having issues based on early treatment with leukemia. How do we present all that very ethically and clearly, communicate it well, as maybe Amy could help us do, and then be sure that we have done our due diligence in all of that? And I maintain that we have still a ways to go to get that right.
Well, so I'd say that I believe we as clinicians do that, and we do that in every discussion, whether we're prescribing an antiemetic or whether we're prescribing or recommending or talking about a clinical trial. So I think the point is it's no different for a clinical trial discussion or an approved drug. It's the same discussion. And the second point I want to make comes back to this discussion about placebo, and I'll pass it on to my colleague from the FDA. But for the point of this meeting and the focus that we have on translation and comparative oncology, I am not aware of a comparative oncology study that includes a placebo. And so the vast majority of this discussion should focus on drugs that are being approved for animal health. That's where that discussion really lies. It doesn't really lie in the phase 1 and phase 2 early research questions that we ask in comparative oncology. So from the perspective of this meeting, it's an important question, but it's really not a question that is really focused on the issue of translation and comparative oncology.
Thank you. We have time for one more question, maybe over here.
Yeah, hey, it's more of a comment. Chris Sloss, FDA Center for Veterinary Medicine. I thought I'd just comment on the whole placebo. We don't, at the FDA, we don't require placebo. A lot of times, I believe the industry chooses to go with the placebo, mainly because for standard of care, as we've discussed, there is no good standard of cares for some of these cancers we're talking about. And the ones that there are standard of cares, the efficacy is not truly known. I could be wrong, but I'm inferring that maybe the drug companies are a little intimidated to go up against these standard of cares when they don't actually know what the effectiveness rate is going to be in these drugs. So they often do choose to go with the placebo, which, as Dr. Vail pointed out, there is these early escape clauses. If a progression of disease is seen, they can escape within a week or two of even starting on these investigational therapy or the placebo. Another option is the historical control, which, as David Vail pointed out too, is kind of not as likely to accurately use a historical control, which is basically not using any secondary group, just adequately characterizing the course of the disease in a population. It's pretty hard to do for most of our animal drugs because we just don't know the natural course of disease. My other comment regarding the ethics too is pretty much every clinical trial that is conducted for animal drug approval for oncology products has both owner diaries and quality of life forms. So therefore, the oncologist who's the investigator, every visit to the hospital, they're checking, they're doing performance status or quality of life, and they're also looking at the owner diaries for adverse events. So they are very scrutinizing, and I can't comment if it's more than a normal patient, but they're on top of any adverse events that are happening in these animals.
Thank you for being here, and we need to take a break and continue the conversation at break, and we'll start again at 10 o'clock. Thank you.